be taking you through the anomaly scan, how it is done. So, all right. So basically, this scan is usually performed between 8 and 22 weeks of pregnancy. The anatomy of the features systematically from the head to the toe. So first of all, we want to know how the fetus is lying within the mother's uterus, whether the fetus is in cephalic, whether the fetus is in transverse, or whether the fetus is breech presentation. So if the fetus is lying, let's say probably in cephalic presentation, the fetus could be positioned with the head facing downward, or be positioned with the head facing upwards or on either side of the mother. So we want to know how the fetus is lying in order for us to know where we put our probe in order to get the structures that we want. Take, for example, with the fetus that is lying with the spine on the maternal left lateral side, we know that if we put our probe on the right lateral aspect of the maternal tummy, we are going to get an axial view of the fetal face. If we are to put our probe, if we want to image the spine, we know that if you put our probe on the lateral left lateral aspect of the maternal tummy, we are going to get an image of the fetal spine. We are going to get an image of the fetal spine. Then if we are to put our probe on the anterior aspect of the maternal tummy in transverse, then we are going to get a transverse image or axial image of the fetal head. So knowing how the fetus, despite the fact that the fetus is cephalic, knowing how the fetus is lying or having an imaginary picture of how the fetus lies within the mother's tummy will enable us to know where we should position our probe, and it will make the scan quite easy and even faster, because we know if you want the spine, we have to put our probe somewhere over there. If you want the face, or if you want the head circumference, as shown or as illustrated in this image. So having an imaginary picture of how the fetus is lying within the mother's tummy will enable us to do the scan even quick and easy. So moving on with assessment of the fetus, we first want to assess the fetal head. So for assessment of the fetal head, we want the ventricular system, we want to assess the anterior, we also want to assess the middle, and we also want to assess the posterior fossa. So there are two axial planes that allow visualization of cerebral structure to assess the anatomic integrity of the brain, which are the transventricular plane and the transthalamic plane. The transventricular and transcerebellar plane. The transthalamic plane, yes, but most of the stuff would have already been covered by the transcerebellar and transventricular plane. So the transthalamic plane, in most cases, then is used for measurement of fetal biometry. So beginning with the transventricular plane, for this plane, we are in axial view as shown, as illustrated by this image. We want to place our probe this, then we want to place it at a level that is above the fetal orbits, that is above the cerebellum, and that is slightly above the thalamus, in order for us to get this plane. So on this plane, we want to see, on the ultrasound image, we want to see the normal shape of the fetal head. We also want to see the flaps, and we want to see the anterior horns of the lateral ventricles. We want to see the posterior horns of the lateral ventricles. And we want to measure the ventricles at the level of the parieto-occipital fissure, perpendicular inner to inner within the posterior ventricle. and then the measurement of the ventricle shouldn't be more than 10 millimeters. So these are the structures. So this is an image, or this is a diagram illustrating how to move the transducer from various incorrect sections to obtain the correct section on which to measure the BPD at the level of the transventricular plane. So these are some of the maneuvers that you might make on the probe in order for you to get a perfect image of the transventricular plane. So moving on from the transventricular plane, you rotate your probe caudally on the posterior aspect in order for you to get to this plane where we see the cavum septum pellucidum, where we see the flux, the thalamus, we see the cerebellum, we see the cisterna magna, and we are also able to measure the nuchal fold at the distal end. So the transcerebellar plane is usually used for assessment of the posterior fossa. It also enables to get an assessment of the mid portion of the brain there, because we can see the thalamus. So on this plane, we want a normal shape of the head, which should be ruggedly ball-shaped. And then we want to see the cisterna magna, which is a fluid-filled space behind the cerebellum. So we measure it from the posterior aspect of the cerebellum to the anterior aspect of the occiput. Then the diameter shouldn't be more than 10 millimeters in order for us to say it's normal. Then we want to see the two cerebellar hemispheres, and we also want to see the vermis. So beginning from 20 weeks when we do the scan, there shouldn't be any communication between a fourth ventricle, which lies somewhere over there, and the cisterna magna. Then we also want to see the thalamus, and we also want to see the cavum septum pellucidum, which appears as a rectangular hypoechoic area in the anterior aspect. So when we have assessed when we have done the transventricular plane and we have done the transcerebellar plane, we have assessed much of the fetal brain structures. Then the transthalamic plane can also be done. But in most cases, it is done for assessment of the fetal head circumference and for assessment of the parietal diameter, which we measure from outer to outer margin of the scalp at the level of the thalamus. So some departments, they use outer margin to inner margin, but still at the level of the thalamus. Then we now move on to the fetal phase. We now know how the baby is lying within the mother's tummy. We now know the region where we expect to get certain views. If we are to place our probe as demonstrated on this picture, and in longitudinal plane, we are going to get a sagittal view of the fetal face. So what we expect to see is the forehead, we expect to see the nasal bone, the maxilla, and we expect to see the mandible. So the nasal bone shouldn't be any frontal bossing, neither should there be any sloping, or we shouldn't see any proboscis. Then we also want to see the nasal bone. So the nasal bone has to be present. It has to be long enough. We measure it, and it shouldn't be hypoplastic. Neither should it be flat, or should it be absent. Then we also want to see the maxilla, and we also want to see the chin. And the chin shouldn't be too small, as in cases of micrognathia, or it shouldn't be directed backwards, as in cases of retrognathia. So if you are able to assess the fetal face in sagittal view, then definitely you are also able to assess the fetal orbits, because we just rotate the probe 90 degrees at this level, and we are going to get a good image of the fetal orbits as it is demonstrated on this image. So just a rotation of the probe from the sagittal view will enable us to get a good picture of the fetal orbits. The beam is cutting from the orbits. As you can see, the orbits are the most up high anterior, and the occiput is posterior. So the occipital bone is the distal part that the probe is going to reach. So on this image now, for assessment of the orbits, we want to see the two orbits. We measure the size of the orbits, and they shouldn't be too small. The orbits should be present, and we also want to assess the interorbital distance. We should be able to fit in a single orbit between the two in order for us to say this, the interorbital distance is normal. So from there, we then go on to assess the
we seem to no longer be hearing you, Mr. Chigayo.
Okay, so in most cases, we see people assessing the fetal orbits on this view, which is not the correct position where we should assess the fetal orbit. So this is more of an axial view of the fetal head rather than the correct or proper view that we want when we are assessing the fetal orbit. So this is a wrong view. So if you are able to, we started in the sagittal plane. We assess the sagittal plane of the fetal face, and then we went on to the axial plane. So if you are able to assess the fetal eyes on this plane, then you are also able to assess the you are also able to assess the maxilla, because just distal to the orbit. We are also able to assess the palate, sorry, because just distal to the orbit, you just slide your probe distally from the orbit, still in axial plane, in order for you to see the palate. So these are the tooth buds, and that's the palate. This is the region where we rule out cleft lip. Then we move our probe into the coronal plane now. So for the coronal plane, we want to assess the fetal nose, and we also want to assess the fetal lips. So to rule out cleft lip, this is the image that we want. So after that, we are done assessing the fetal head, and we are also done assessing the fetal face. Then move on to the fetal heart. So our probe should be in transverse plane, directly on the fetal chest is shown on this image. So assessment of the fetal heart, we do it in axial plane. There are four images that we want. We want to assess the four-chamber view. We want to assess the left ventricular outflow tract. We also want to assess the right ventricular outflow tract and the vessel tracheal view. So all these images are obtained in axial. The trick is just tilting the probe towards the fetal head and slight angulation either to the right or to the left of the fetal shoulder in order for us to get all these four views in transverse. So the four chamber, we are at this level. We move up slightly, we tilt our probe slightly upwards, and our probe is directed more to the fetal right shoulder. We get a left ventricular outflow tract, and then we tilt it even up high slightly, and we rotate it towards this time towards the left fetal shoulder. We get a three-vessel tracheal view, and if we slide our probe up high and slightly tilt it again towards the fetal left shoulder, then we are able to get the three-vessel tracheal view. So dealing with the four-chamber view, we should assess the four-chamber view beginning from the level of the fetal abdomen. In order for us to assess situs, we want to see the stomach bubble on the left and the descending aorta more on the left. We move our probe still in transverse plane up to the level of the chest, and we should see the heart more on the left side. So at least 3/4 of the heart should occupy should be on the left side and a third on the right side for us to say there is normal situs. Then from there, we want to assess the axis. The apex of the heart should be at least 45 degrees directed towards the left side. So if we are to draw a line in cutting across the ventricular septum, we should get an angle which is at least 45 degrees plus or minus 20 degrees in order for us to say there is normal axis. Then we also want to assess the fetal heart size. So the heart area, the heart should occupy at least 1/3 the area of the total chest area. So, but measuring the chest from the outer margins of the ribs rather than from the outer skin margin. Then we also want to assess the ventricles, which should be of almost similar size. The right ventricle, the morphologic right ventricle, should have a moderator bend, and the left morphologic left ventricle should be apex forming. And we assess the valves, which should be freely moving, with the tricuspid valve a bit more apical as compared to the mitral valve. We also go on to assess the atrium, which should be of almost the equal size, and we want to see the foramen ovale with the foramen ovale flap opening into the left atrium. We also go on to assess the pulmonary vessels, which we should see entering the left atrium, and just below we should see the aorta, which should be the only vessel that we see just below the pulmonary vessels. Then from there, we also assess the outer margins of the heart to exclude any cardiac effusion. Then from there, we slightly rotate our probe to the fetal, towards the fetal right shoulder, and then we tilt it upwards in order for us to get a view of the left ventricular outflow tract. So for the left ventricular outflow tract, we want to see the aorta coming from the left ventricle, rather the morphologic left ventricle giving rise to the aorta. We want to see blood flow out of the fetal left ventricle into the aorta. So we slightly rotate towards the fetal right shoulder and slightly angle the probe upwards cranially, and then we can get a good image of the left ventricular outflow tract. So on this left ventricular outflow tract, we want to see the aorta originating from the morphologic left ventricle. We want to see the right ventricle, and we also want to see the left atrium. We want to assess the anterior wall of the aorta, which should be continuous with the ventricular septum, and the posterior wall of the aorta should be continuous with the mitral valve, and the valves should be freely moving. We go on to assess the three vessel tracheal, the right ventricular outflow tract. So on this one, we slightly rotate towards the fetal left shoulder and angle it a bit more in order for us to get a view of this image. We want to see the right ventricle. We want to see the right ventricle, the right atrium, the pulmonary vessel, the pulmonary valves, which should be freely moving, the aorta, and we also want to get a view of the right pulmonary artery. So this is the right ventricular outflow tract. The main pulmonary artery should be slightly larger than the aorta, and there should be a free movement. And also, we can apply color Doppler to assess blood flow through that right ventricular flow tract. Then, if we are to slide probe upwards, slightly tilt it towards the fetal left side, we then get a view of the three vessel tracheal view. So the three vessel tracheal view, basically the transverse portion of the aorta, the pulmonary arteries, it gives rise to the ductus arteriosus. That's the V configuration that we see over there. And then there is a superior vena cava that we are going to cut across with the beam, so it will appear in cross-sectional view. So direction of blood within that transverse aorta and direction of blood from the pulmonary artery into the junctus arteriosus is in the same direction. So blood flow in these vessels should be in the same direction, and blood flow in the superior vena cava should be in the opposite, because this one is flowing into the heart. And then on this view now, we want to see the pulmonary artery should be a bit larger than the aorta, which should be a bit larger than the superior vena cava, and we see the thalamus posterior to the superior vena cava. And then we also assess for position. So we begin from left, we begin with the pulmonary artery, and then the aorta, and then the superior vena cava. And then the issue of blood flow that I mentioned, the other thing that we assess on this view. So blood flow is always towards the spine. Then moving on from the heart, we go on to the circumference.
Mr. Chigayo, I think your time, yes, you are already eating into the next presenter's time. Probably I'll give you a minute to just sum up, or probably you can give the other sections, because the brain and the heart on their own, I think they have so much information.
All right, so just to round up, so by continuous movement of the probe on the abdomen in transverse view, we can also get the abdominal circumference, and these are the structures that we expect to see. And moving downwards, we can also get the condensation. And if we further move the probe downwards again, still in axial, we can image the fetal urinary bladder. And then if we are to image the kidneys, we are to place the probe as shown, as illustrated on this diagram for the transverse, where we measure the renal pelvis, and for the coronal, and for the sagittal view. And then we should also assess the fetal spine. So assessment of the fetal spine is quite easy, and from the fetal spine, you can easily go to assessment of the fetal kidneys. Then we also assess the fetal extremities, is shown in this diagram. We have to assess the femur, we have to assess the tip fib, the foot, and we also have to assess the humerus, the radius and ulna, and all the fetal digits. And then after that, we can safely say we've completed the anomaly scan, and that's the end of my presentation. Thank you.
Thank you so much for the insightful talk about performing in detailed anomaly